There we go.
Okay, so looks like we are good to go. So my name is Josh Wilson. I'm the Acting CPD Officer here at the North East Musculoskeletal Society, otherwise known as NEMS. For those that are new to NEMS, we are a non-for-profit organisation on a mission to raise the standards of MSK clinicians from our base here in the North East of England. We aim to provide free quality CPD with a mixed virtual and in-person format, with the highlight of our year being the summer conference. So do be sure to keep your eyes out for that towards the start of next year. Our speaker of the evening is Mahin Kohli, an advanced practice physiotherapist specialising in persistent pain. Mahin is also a community pain champion and also creates some great social media content under the handle of The Wellness Puzzle. I think the speed at which the tickets went for this evening demonstrate the relevance of the topic being discussed. With an increase in prevalence of persistent pain and an increase in number of FCP services, it creates a real challenge for how do we manage these persistent pain states with more condensed appointment times. Just some basic housekeeping before we get started. You may have noticed that your cameras and microphones have been disabled. There will be a Q&A section, and all that you've got to do to ask a question is if you just pop it in the chat feature. Sam's going to collate the questions and ask them to Mahin at the end. And the slides will be shared on the back end of the presentation as well. So just keep an eye on that coming through in your email. That's when you're ready, Mahin.
Thank you very much. Okay, so yeah, thanks, Josh. Give me an introduction there. As Josh said, my name's Mahin. I'm an advanced practice physio working in pain management in Wolverhampton. I work within a primary care integrated MSK pain and rheumatology service. Bit of a disclaimer up front, I'm not currently doing FCP clinics at the moment, but working in primary care and work with other FCPs as well. I'm also an independent non-medical prescriber. However, most of my role is helping people reduce off pain medication, such as opioids, that is no longer helping their pain, and replacing these with active non-medication strategies instead. I'm also really pleased about recently becoming a flipping pain community champion. If you haven't heard of already, check them out, then I really recommend looking at this public health campaign. Flipping Pain's goal is to change the way we think about, talk about, and treat persistent pain. And the website, which is flippingpain.co.uk, that's flipping without a G, is a fantastic resource for as a one-stop shop really to signpost patients to. It's one that includes lots of other websites and resources on there. So it's got stuff for patients, healthcare professionals, and those caring for people with pain as well. I've also got my own YouTube channel, and that's called The Wellness Puzzles. Josh mentioned that as well. The Wellness Puzzle is aimed at increasing people's awareness of chronic pain and the different ways to manage it. I'm always shamelessly pleading for subscribers, so if you do find today helpful, please do subscribe. Otherwise, I'm on various other social media platforms, as you can see. Outside of work, I play cricket. I'm not going to talk about the recent World Cup. I've recently started CrossFit, and I love traveling to new places. I'm really excited to be speaking today about managing persistent pain in primary care. As I see, this is a great opportunity to have a significant impact on the sustainability of our healthcare system. I understand it's a massive, massive topic to fill in an hour and a bit, but I'm going to do my best, and I'm going to keep it as practical as possible because I just want you guys to be able to take stuff into your clinics tomorrow, Friday. So yeah, trying to keep it as practical as possible, really. I'm also going to talk about values-based rehabilitation towards the end of the session, and it's something that I'm hugely passionate about. Identifying people's values and helping them connect with these alongside their pain is my underlying aim as a clinician, and it's something I explore with all my patients. Okay. We'll hopefully have some time for questions at the end, so please use this so we can hopefully make some of the learnings individualized to your practice today. Wanted to keep it really informal, so ask questions in the chat as we go along, or stop me if you need anything explained in more detail. I can't see the chat at the moment, so just going to ask one of the guys to maybe prompt me if anyone says anything, or if I'm not making any sense, which often happens as well. Okay. So just a couple of learning objectives really before we get started. So what we're hopefully going to get from today is to be able to identify, define and alter management appropriately for individuals with different presenting pain mechanisms, to gain confidence in your ability to help a patient make sense of their pain presentation, to use your knowledge of different pain mechanisms to explain why certain treatments or strategies may or may not be helpful, and to reach an informed shared decision with the patient about the next step in their management based on all of the above. Lastly, really to identify our role as primary care MSK clinicians in helping people live with chronic or persistent pain using a values-based approach. So how we'll achieve these learning objectives in the next 60 minutes or so is by hopefully improving your confidence with each of these common steps as we go through in primary care with patients with chronic pain. Each consultation, of course, with different patients will look different, but these are the 4 stages that most of us will naturally go through, and these are so important for getting it right at the first point of contact, or at least as close to it as possible. I've purposefully left management off here as dependent on the patient and your local service offerings. There may be a referral onwards to another service, whether that's physio, pain management, following the shared decision-making discussion. I also don't think it's possible to fit all of this into one consultation for every patient. So this may be over 2 appointments. A lot of patients that you see with chronic pain will have had this pain going on for a number of years. I think we're sometimes asking too much of ourselves to try and change any of that significantly within one consultation. The likelihood is you're going to have representers that do come back. So taking your time and spreading this out over a couple of consultations is probably sensible. It probably saves on future appointments down the line as well when we're taking a little bit more time with these initial bits. As a rule, generally, I do say that if a patient's come to see you for the 3rd time or more in a relatively short period of time, it's probably worth considering referring onwards to a physio or pain management service, as they'll have more time per appointment than you will in your FCP clinic. But to begin with, I'm going to run through a very quick and basic overview of pain, how it works and the different pain types. I am keeping this brief and simple just because I know today's webinar is more about the management of pain. So quick overview on what pain is. So an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This was the first revision since 1979 that's been done, and the change in this is the part where it says or resembling that associated with. So a long time for that little extra phrase in there. We've also then got chronic pain. So obviously pain that lasts for longer than 3 months, also referred to long-term or persistent pain. And chronic pain is either secondary or it's primary. The chronic primary pain is when pain has persisted for more than 3 months and is associated with significant emotional distress and or functional disability, and the pain is not better accounted for by another condition. So here we're thinking of things like fibromyalgia, chronic widespread pain, CRPS, chronic primary headaches, etc. And it's chronic primary pain that a lot of today's focus will be on. Okay, so quick key things for pain. So pain's primary role is protection. All pain is an output of the brain, regardless of what type of pain it's going to be. I'm going to go into the different types of pain today, but regardless of the type of pain, all pain is an output of the brain. Pain does not equal damage. And pain is always real 100% of the time, regardless of the type or cause. So just to kick us off, I'm going to give a quick overview on how pain works. And I'm going to use this candle that I've got here in front of me. I haven't done this with a real candle before. I usually just use a mug or something. So if I do burn myself, then I'm going to probably not do this again. But I just want you to imagine for a second that I'm holding my hand over this flame. I don't have to imagine I'm doing it. What I'm feeling initially as I do this, I'm feeling the warmth in my skin. If I hold it there for a little bit longer, that's getting uncomfortable now, to the point actually where I'm feeling it's now kind of painful and I'm taking my hand away. So this all happens relatively quickly, and just as a quick overview, I'm going to explain what's happening here. So the nociceptors within my skin and my muscles that are detecting there's a change in temperature. Nociceptors also detect changes in mechanical pressure and chemical changes as well. But the nociceptors in this example are detecting there's been an increase in temperature. So what it does is it sends a signal across the first neuron to my spinal cord saying there's been an increase in temperature. This is not pain yet. This is just an increase. This is just a signal saying there's been an increase in temperature. If that signal is strong enough, it'll jump across the synapse to a second nerve and travel up to my brain saying there's been an increase in temperature. The brain will then make a decision on whether this needs protecting against or not. And it will draw on lots of different bits of information to make that decision. So it will take in my environment, it will see a potentially hot flame. I can smell the wax burning for anyone who's interested. This is, oh, it doesn't say Oh yeah, jasmine. If anyone's interested, the scent of the candle, you can smell the jasmine. It can smell the wax burning. It can maybe hear a little bit of the crackling that's happening. It also knows that I'm speaking to a fair few people on a webinar, which might make me feel slightly uncomfortable. All things pointing towards threat or danger. It will also think back to my past experiences and my memories. So when I did this last week, I held my hand over the flame for a bit too long. I got burnt. That's dangerous. Probably shouldn't do that again. And it'll also think about the future. So it'll make predictions about what's the most likely outcome if I keep my hand over that flame. Now, all of these things are pointing towards danger. And what the brain will do is it will weigh up whether there is more evidence for safety or more evidence for danger. If there's more evidence for safety, the brain won't produce pain. But if there's more evidence for danger, like in this example, then the brain will produce pain. It will send it down through those nerves to my hand with a pain sensation, causing me to take my hand away. Remember, pain's role is protection. So that I feel pain, it causes me to take an action to protect myself from that potentially harmful stimulus. So that is how all pain works. Okay, pain is always an output of the brain. Now, our biggest change in understanding has been that we don't need this upward nociceptive signal to get the pain response. This is just one of many factors that are involved in this way up of the brain, where there's more evidence of danger or more evidence of safety. We now know that even without the nociceptive input, this balance is still happening. Things like chronic stress, previous trauma, are things that can often lead the evidence of danger outweighing the evidence of safety, amongst lots of other factors as well. So that's just a quick overview on how pain works. I won't go into too much more of it today because, as I said, we're focused on management of pain. Okay, so if we're looking at the types of pain, then we don't like to make things easy for ourselves because they all begin with N. They all sound fairly similar. But we have three types of pain here. Now, nociceptive pain is effectively what I've just described here with the candle. And this is caused by stimuli. So this might be injury, damage, inflammation, tissue changes, any potentially harmful stimulus that activates nociceptors. Okay, and this examples of nociceptive pain are things like osteoarthritis, rheumatoid arthritis, rotator cuff related shoulder pain, spondylosis, etc. Things that are often seen, structural things that are seen on scans and can point towards nociceptive pain. This is where conventional treatments, so things like medications, injections, surgeries, tissue-targeted exercises can help, okay? We then have neuropathic pain. So this is caused by a lesion, damage, or disease affecting the nerves. And this could be things like sciatica, carpal tunnel syndrome, diabetic neuropathy, spinal cord injury, post-stroke pain, MS, trigeminal neuralgia, the list goes on. This is where medications, injections, surgeries, for example, nerve decompressions, sometimes help, but less so the longer that someone's had symptoms. So the more chronic it's become, the less likely these conventional treatments are likely to work. We then have a third type of pain, nociplastic pain, and this is the type of pain that we're understanding more and more about. Nociplastic pain is caused by a disturbance in peripheral or central nervous system pain processing. And examples of this might be chronic widespread pain, fibromyalgia, non-specific lower back pain. Nociplastic pain is the chronic primary pain that I was talking about a couple of slides ago. And it's pain that is lasting despite normal tissue healing time or pain that has no identifiable cause. So often things where we're having tests, investigations, blood tests, scans that are coming back are not showing a clear indication for pain. For nociplastic pain, conventional treatments do not help, unfortunately. And this is where we need to move away from tissue-targeted approaches to values-based rehabilitation or values-based approaches, which I'm going to speak about at the end of today's talk. So this is why it's really important to know the difference between these three types of pain, because it's not always that we can put one treatment that works well for one type and apply it to another and expect the same results with that. It's also really important to know that someone actually may have a mix of these pain types at the same time. So let's take someone with spondylosis, for example, lumbar spondylosis. And because of the changes that have happened, the structural changes, they're also getting some nerve root irritation and they present with sciatica. But also because they've had this now for 2-3 years, they've also started to develop chronic widespread pain. So here we can see the spondylosis, which is nociceptive pain, the sciatica, which is neuropathic pain, and then the chronic widespread pain, which is the nociplastic pain. So the problem is that conventional assessment, diagnostic tests and treatments are mainly focused on nociceptive and neuropathic pain. And in my personal opinion, this is the biggest problem we face as MSK clinicians in primary care and arguably as a health system, as investigations and treatments for these two types of pain do not show or typically help treat nociplastic pain. And we're trying to use the same assessment tools and the same treatments for nociplastic pain. And it's like trying to fit a square peg in a round hole. So it's something that isn't working at the moment, and it's something that we need to change. I'm not going to go into assessing for these types of pain today, as again, this is focused on management of persistent pain. But if you are unsure about how to assess these, I would recommend starting here, as knowing the mechanism of pain is so important. Okay, so kind of carrying on from my last point, there is no such thing as a pain test. So none of our conventional diagnostic tests specifically test pain. So X-ray, CTs, MRIs, they assess structure, intensity, density. Blood's assessed biochemistry, but we cannot tell from a test if someone is experiencing pain. It goes without saying, we know this now. This is kind of not new news, that the pain does not always relate to structure, and this is why these tests and other things do not always show pain. It's really important for our language to change based on this. So, as an example, rather than saying test for your pain came back normal, instead we might say your MRI did not show a clear structural involvement for your pain. I know this is subtle, but this makes a massive difference, and patients are less likely to interpret these test results as you can't really be in pain because your tests don't show a reason for you to be, or it's all in your head because your tests have come back normal. It's also a really good time to remind patients that pain can exist due to a variety of factors beyond structure alone. And it's also, I think, sometimes frustrating for patients when tests are coming back not showing a clear explanation, but it is a really good in for us as clinicians to actually say, okay, well, this is the reason why things don't show on tests, and going into the wider factors that may influence pain as well. Okay, so I'm going to give our voice a bit of a break here and just ask you in the chat to kind of type in what do you feel the purpose is of an assessment? Why do we do an assessment for chronic pain? What's the kind of point of it? What are we trying to get out of it? I can't see the chat, so I'm just wondering if anyone can kind of read things out.
We're just working on the chat feature now, Mahin. It's I think Steve's in the background trying to get that working, but it's limited to just panelists at the moment.
Okay. Just let me know if we can't get there. That's not a problem.
Recording in progress.
I can.
So I've just seen something pop up at the top of the screen there, which it looks as though the chat's been open. So I don't know if people want to try using it there.
So I've just logged on from my phone. It still says chat disabled, I think, for this part.
So it looks like the Q&A function is working now.
Yes.
So we could use that as a workaround for the time being if people wanted to put their answers in there.
I can see the chat now as well. Thank you for that. So yeah, just typing in really, what is the purpose of an assessment? What are we trying to get out of the assessment here? Kind of read things as they come along. So yeah, we've got assessment will help to understand the patient's thoughts about pain and the cause of it. Absolutely. Gaining an understanding of the patient's expectations. Yeah, really, really key, I think, initially, especially if patients have have seen lots of different professionals before. Differential diagnosis, type of pain, nociceptive neuropathic, yep. Screening, see how pain affects function, impact on life. type and severity of pain, along with how much impact it's having on the patient, rule out red flags. Yeah, screening for serious pathology, of course. Fantastic. Yeah, all really kind of good stuff here that's coming in. Okay, so just slight change then with this. So there are some things that are coming through in the chat. Let me rephrase this as, so we've got mostly the things that what we want as clinicians from the initial appointment. What do we think a patient wants to get from it? Might be slightly different, might be the same. Validation, reassurance, understanding, yeah. Clarity on the symptoms, absolutely. Tell you the story of their pain. Fantastic. So slightly different things there. I think sometimes we can go into an assessment wanting to get certain answers to certain questions, mainly around the diagnosis, eliciting goals, that kind of stuff, and patients may come wanting slightly different things. That's not always the case. Sometimes they align. Patients are coming for a diagnosis, and we help them reach that. Sometimes patients just want the opportunity to tell their story, and often FCP appointments are obviously shorter than what we would have in physiotherapy or pain management appointments, but still have slightly more time than potentially GPs, where patients may have the opportunity to kind of discuss things through. Fantastic. Yeah, loads of good stuff coming through in the chat there. So I'll leave that one there. But thank you. Okay, so most everything covered off there in the chat. So we're of course screening for serious systemic or any other underlying pathology that might be causing pain, depending on what that might be. And it might lead to a referral elsewhere, whether that's through emergency pathways, urgent pathways, or it might be a referral onto another service, or even a review with the GP as well, if we think that something's masquerading as the widespread pain. We also want to listen to understand the patient's journey, to, like people said in the chat, providing validation, using their own experiences, and particularly to facilitate education later on. I think sometimes we lean a lot on what the research tells us. And I think for patients, sometimes the anecdotal evidence that they have had in their own lives holds more weight when we're using it to facilitate our education later on. Understanding the expectations for management and prognosis, and are these in line with the likely prognosis and treatment? Mismatch in expectations can also be quite harmful to the relationship we have with patients and patients with us. Identify values and goals, and then finally agreeing a management plan in collaboration with the patient. Okay, it might be an opportunity to then explain the role of what your role is in an FCP clinic, or potentially what the role is of a service that you are referring to. So these are kind of the stages of the assessment. Again, I don't think this has to all be done in one appointment. In my pain management clinics, when I have a lot more time, I have 50 minutes for new patients. I often don't get through all of this in one appointment. If I'm completely honest, this stuff takes a little bit more time. In an FCP appointment, it's even tighter, of course. But what we're really looking at here is asking the first question, am I the best person for this patient right now? Or is a referral warranted elsewhere? As we mentioned, the stuff for serious conditions if we're suspecting them, but also, rheumatology. Has this person had a good workup from rheumatology if they're presenting with widespread pain and potentially inflammatory features? Do they need a mental health service before even physiotherapy? Is actually their anxiety, depression, the main barrier in them moving forwards with this? It can be really helpful to have that alongside pain management work or physiotherapy. Or do they need to go to their GP because this is not looking MSK related or chronic pain, chronic MSK pain related? So we're looking really at assessing the type of pain as well, and then we've got education. So education can come in after the assessment of the type of pain, or it can come after identifying values and goals. And I think it's going to be specific to where this fits more naturally in the conversation for different patients. And what's really important is we can't do the shared decision-making discussion well if we've not done the steps before it, because we need to know what type of pain is presenting first of all. We need to know what the patient's expectations are and what their goals are before we can then decide on a management plan. So remember, the patient is the expert when it comes to their pain. Our initial role is to understand their pain and journey. Living with pain is not a choice, it's very distressing, especially when test investigations do not provide answers. There is a possibility that a reason for the pain may not be identified. It's good to be honest with that about patients, I think. And it's good to be open about the possibility that the pain may not improve or go away completely. And it's probably the moment in my pain clinic when often we get the tears is when kind of we have that discussion. I think a lot of patients who've been living with pain for a number of years have probably already come to that realization, but sometimes verbalizing that is difficult to hear. But I think it's also really good as a turning point and moving towards acceptance and then moving forwards with the pain when there's actually someone's been open about the possibility that the pain may not go away completely. And of course, there can be improvements in quality of life, even if the pain remains unchanged. And I think what we're trying to do here is improve function and quality of life. We can't always have a direct impact on pain. Okay, so coming on to management planning then. So we want to link the plan back to the patient's type of pain. So thinking of the 3 N's we spoke about, their journey, to reflect on the treatments that they've previously tried and the long-term effects of these, and offering a way in to propose a new approach. Their expectations, and as I mentioned, that's both for prognosis and for treatment. Ultimately, are they ready for the approach that you're offering or referring onwards for? Because if they're not, it can erode the relationship you have with the patient due to mismatching expectations. Sometimes we try to make patients go down a certain route, and that's because we're in a caring profession. We're wanting to help. Sometimes the patient may not be ready for that, and sometimes just leaving them with the option to come back when they feel at a stage to take on the next step once you've explained it to them can be more helpful for them in the long term. And finally, do they need a referral elsewhere? Are they ready for the approach that service offers as well? So the main things in management planning and the kind of stages that I think a lot of people go through is education, acceptance, and then living well with pain in line with their values with help from pain management strategies. Okay, so when moving towards acceptance and living well with pain, this golden shift must take place. And it's the shift from what's the matter with me to what matters to me. And this is a shift from a diagnosis-driven and attempting to control pain state to a goal and value-focused state of living well with pain. And it's really, really key that this happens before moving forward. And this requires a collaborative approach between you and the patient as well. It's important because the more time, energy, and resources that are spent on trying to find a cause and control the pain, the less time, energy, and resources are available to do the things that patients want to do because they love and enjoy them. So why is it important for that shift to happen? So struggling for pain control is the best predictor of worse pain, poor activity, greater disability, worse depression, and greater avoidance. And although pain's reported, people access their GPs, FCPs, or physios because of the secondary effects of their pain. So often we find it's because it's now starting to have an effect in other parts of their lives. And some analogy I kind of use with patients is if you're standing in front of a lake and you've got a stone in your hand, the stone represents your pain. If you throw that stone into the water, the ripple effects that you see are the secondary effects that pain has had on your life. And more often than not, although patients report pain, they're coming because of those secondary effects that pain started to have. So to help start the shift that I talked about in the last slide, I often ask patients to reflect on the previous treatment outcomes in the long term that they've experienced. And I ask patients, are these strategies that you're using or treatments that you're using to eliminate or control the pain helping you to live the life that you want? If not, can we move forward with the pain? Can we make space for it in your life if it's going to be there anyway? So rather than waiting for pain control or pain to get better, can we help moving towards patients' goals in the presence of their pain? And I think this is really where I feel we can stand out as clinicians in someone's pain journey, because rather than offering singular approaches with the aim of controlling pain, whether that's medications, injections, exercises alone, we have the opportunity to really explore what matters the most to people and facilitate them in moving towards that. It's also likely to take a number of appointments over a period, but we are reframing the expectations away from pain relief towards valued living, which can significantly reduce the pressure on both yourself as a clinician and the patient as well. I feel like patients appreciate the honesty and the new approach with this, rather than kind of attending and someone telling them that their pain can be helped with this particular treatment. I think patients have often, especially with chronic pain, tried lots of different things and seen that that isn't the case. And this new kind of way of kind of approaching things is quite valued. Okay, so somewhere between education and valued living comes acceptance, and acceptance is the most difficult yet most important step in living well with pain. And I argue that it's hard to move forwards until this stage has been reached. So acceptance doesn't mean giving into pain, as the word often suggests, but rather having a willingness to move forward in the presence of pain towards valued living. So this is a quote that's taken from a patient. I'm just going to kind of let you read for a second. So not an easy stage at all to reach that acceptance for clinicians to help patients on that journey, but also for the person living with pain as well. It often involves them going through a change of identity and also accepting that maybe the activities they did previously, they may not be able to engage with them in the same way, but there are ways in which to engage with the meaning behind that activity, which I'll speak about. So this is a pain cycle that I'm sure a lot of you would have seen, and this is it's by Live Well with Pain. I often show my patients this because they find that they can resonate with this quite clearly. It can be really helpful in reaching an understanding of why change is needed in their approach to manage pain as well, because a lot of patients find that they do find themselves in that cycle. Just give you a moment if you haven't seen that to kind of read through. Because this cycle does have a lot of words on it, I often use this simplified version, especially if I am referring into our rehab team or for physiotherapy. So the way that I often explain this to patients is when you have pain, naturally, there is a fear or a concern or a worry that the pain is going to get worse or that you're going to do something to flare up the pain. Now, either consciously or subconsciously, that leads to an avoidance of activities that are painful. Remembering that pain is our protector. So when we feel pain, the natural response is to avoid, and that's completely normal. That's fine in the short term, but in the long term, that avoidance leads to a reduction in strength, movement, function, mobility, or any kind of function related to that activity. When we're not able to do things that we enjoy, that can lead to low mood as well, and that pain cycle can continue going around. I don't think I've ever had a patient say to me that they don't resonate with this cycle, because I think a lot of patients find themselves in it. Now, the important thing is to then explain how we can maybe look to reverse this. So the way that I explain this is we can't always help with the pain, and patients often know that better than we do. Pain is not an easy thing to get control of. We can't always help with the fear either, because they're human at the end of the day, and that fear is natural. But where we come in is how can we gradually being the key word, help people exposed to those previously avoided activities again, hopefully with the intention of improving strength, movement, function, and helping them to re-engage with their valued activities to improve their mood. And hopefully in the long term, we're seeing that the sensitivity of pain reduces as a result of that. In short, the more we avoid, the more painful things are when we return. The more we're exposed to things, the easier they should be when we return. I think this cycle is a good way of getting some buy-in from patients before suggesting increasing physical activity or beginning exercises. A lot of patients would have already tried physio or exercises before. A lot of them would have had poor experiences with it because it's flared up their pain. I think the important thing is showing them why this is important and helping them understand the reasoning behind it, which is key. Using the word gradual increases as well is really important, I think. Now, the self-care cycle is obviously the other way around from the pain cycle, and this shows the many different strategies to help manage and live well with pain. It quite clearly shows there's not a single cure, fix, or best treatment, but a combination of different approaches focused on the individual and their situation. And there come 5 pillars of health: physical activity and exercise, diet and nutrition, sleep, mental well-being, and social connection. All of these things are seen within this cycle, and these are also all pain modulators as well. Okay, so it's not all about exercises. Well, and that's quite a bold statement, especially from a physio. Not many physios that would probably say that. The reasoning behind this slide is, so we often give exercises to people that increase their pain. So, I mean, what's the likely response? So people can just pop quickly in the chat what they kind of think the likely response is here. So given exercise, people, it increases their pain. What's the likely response from patients? Yeah, I'm not getting any through, so I don't know if that's just because the chat function is not working, or yeah, there we go. Thank you. Need to get at least one response. Yeah, pain gets worse with exercises. What's the likely response? If pain gets worse with exercises, what's the response from patients? There's an obvious one, but there's also another one as well.
There's quite a few coming through, Mahin. It might just be a little bit of a delay in them getting to you.
Okay, no problem. Thank you. Yeah, I'm not getting any on here.
I can read out some of the main themes.
Yeah, just a couple if that's okay. Just the common themes that are coming up, please.
Trust is a huge one. So people are saying a loss of trust in you as a clinician, increased fear or anxiety, poor adherence with exercises, negativity towards activity overall, increased use of GP or medical appointments, so seeking a different provider of care, or just giving up on physio. I think that probably,
yeah, that's good range there. No, Chan, thank you. That's awesome. Thank you. Yeah, absolutely, like, spot on. The main likely responses, and I think kind of these two things sum up what was said there in the chat. But patients either stop and avoid, or they push through and make the pain worse. Kind of a response where it's like, okay, well, I've been told to do these exercises, they are hurting, I'm going to push through anyway, I need this to get better. Ultimately, like mentioned, it increases the fear around exercise, which can be really, really hard to undo. So whether they're avoiding or they're pushing through, both situations increase the fear around exercise. And it's especially the case if the exercises have no meaning to them individually and are not related to their goals. It's important to set expectations around exercise and the likelihood of increasing pain, but also to set exercises specific to individuals' values and goals. The reason being is people need to know why we're advising them to do certain exercise or activities and how it ties in with what they're trying to achieve. This is why understanding what's most important and meaningful to people is critical in that initial bit when we're discussing it with patients, because then we can target their rehab towards this. If put yourself in kind of patient shoes, if you go to see someone, you've had a problem that's been ongoing for a number of years, and at the end of the consultation you're given a sheet of exercises that look quite standard. If I was given that sheet of exercises and I was living with pain for a long time, having tried them before, I'd probably put them straight in the bin and I probably wouldn't do them. It's really important to help patients to see why we're doing those specific things, and that often comes from understanding what their goals are and what they're doing towards that. So I have some kind of examples that I'm going to share in a moment with that. Okay, so just want people to reflect, really. We're going to take a little bit of a kind of shift in this webinar now. So we just want people to think about what are your values. This is quite a hard thing to do, especially on the spot, and especially if you've not thought about it before. I'm going to share what my values are. So values are what give our lives direction. Okay, they're what provide meaning and importance to our lives. They're the things that are our core, that shape the way that we act in life and shape some of the decisions in our life. So for me, my core values are personal growth and learning, kindness and helping others, and fun and freedom. So they're things that I live my life by. And if I'm ever faced with a decision, I can reflect on my values and think which path is going to take me closer to my values. a dark way of thinking about your values, unfortunately, is how do you want to be remembered when you leave this earth? So let's say at your funeral, in your eulogy, what do you want people to be saying about you? And that's what helps shape our values. I'm gonna just let you take a moment without me talking over the top of your thoughts, just to think about what your values might be. So I've got some kind of prompts here. Might be what brings you energy, what do you look forward to, what is important and meaningful to you in your life, what would you like to be remembered for? Okay, so just want you to maybe just take a minute or so just to reflect on those questions. Some things might come straight to mind, some things might not. Don't worry, it took me honestly about 2 months to come up with my values. So this is something to maybe even reflect on after today, just from a point of view that it's helpful for even if you don't have pain. I think it's a really, really important exercise to do. I'll put a timer on for 1 minute. My mum just called me as well, always at strange times that she calls me. I didn't think answering it on the webinar would be appropriate, but I'll give you a minute now. Okay, so some things might have come to mind, some things might not have. It's a really good exercise to do here that I'd recommend doing for people, even if you don't have pain. As I said, it can shape some decisions, but the reason why it's important to identify values as patients, the reason it's important to identify values is because patients may not be able to do the same activities that they did previously. But if we're able to identify the meaning beneath their previously important activities, we can help people to engage with that value in a different way. And that's what's really, really important. Patients may really enjoy being outdoors. They might enjoy, mountain climbing, for example. I think that example came up today in the pain management program I was leading. They're not able to climb mountains anymore. And initially they were understandably quite upset about that. But when we identified that the thing that actually brought them more joy was because they were doing it with their partner and because they were walking outdoors, we identified and they could engage with their value in the same way by just going for a normal walk, perhaps, rather than climbing a mountain. So there's just identifying the value beneath the activity is really helpful to help people engage with that value in a different way. So when you do this task later, if you choose to do it, just reflecting on how connected do you currently feel to these values that you identified, and what can you do to feel more aligned to them. And that's also a question to ask patients when we do come up with their values is how connected do you currently feel to them, and what can you do to feel more aligned with them. After a first appointment with patients, we may not get through all of the steps that we need to do. So let's say after the assessment, we've determined that the patient is right seeing us, we might want to have another appointment with them, they don't need any other service. Then one thing we could leave them with as a task is to think about what their values are and potentially think of some goals as well. Okay, questions that I use often to elicit values with patients. So is doing something important or meaningful worth it, knowing you will have increased pain after? If the answer is no, it may not be something they value. But if the answer is yes, then that activity might be a valued activity. Another one that I often use is, if you could take a tablet that would take away your pain completely, with the only caveat being that you are unable to get out of bed, would you take it? If the response is yes, the patient's probably not ready for our service at that point, because they're probably a while off that acceptance. But if the answer, as it most often is no, then the question is, why wouldn't you take it? And it might be because, oh, well, my grandkids come around every Thursday to see me, and I really want to be able to engage with them. You've identified a value there with spending time with their grandkids, and then we can move forwards with that. So why is identifying values important? So it helps to inform our rehab and management plan. But when do we know when to switch from tissue-based to values-based approaches and treatments? With tissue-based, I'm talking about joint-specific exercises, injections, medications a lot of the time as well. But when pain is mechanical and localized in nature, so for example, a tendinopathy, that's when we would shift towards tissue-targeted approaches. And in the tendinopathy example, that might be a loading program for that tendon. When something is centrally sensitized, non-anatomical, non-regional, non-structural, it's variable, it's unpredictable, and it's more widespread, that's maybe when we move away from tissue-based exercises and treatments, for example, injections, towards values-based approaches. And that's what we'd use in nociplastic and chronic primary pain, that shift towards values-based approaches. Don't forget that the pain's role is protection, and pain is always an output of the brain. So ultimately, the brain is weighing up whether there is more evidence for danger or safety. So helping people re-engage with the activities that are most meaningful and important to them helps soothe the threat response and provides more evidence for safety, which over time helps to turn down the volume of pain. But what do we do if the patient is focused on the goal of pain relief? So we're moving now from values, identifying values, to values-based goal setting. So what would we do if a patient, you ask them for their goals and they say, well, it's just to get rid of pain, really, and they're struggling to go further. So questions we can ask them. If I had a magic wand, and we'll always make it very clear that I don't have a magic wand, but if I had a magic wand to get rid of your pain, how would your life look different? Can we begin working towards this in the presence of pain? What did you previously enjoy that you would like to return to? What important activities are you struggling to engage with currently? And what does normal look like to you? So a lot of patients will say, oh, I just want to get back to normal, but what does that look like to you? Once we've identified people's values and the longer term goals, we can help them move towards these. So goals might be anything from lifestyle, work, medication, mood, health, physical activity, social engagement. The list is endless around what those goals may be. But the goal ultimately should be meaningful to the patient, in line with their values, and functional rather than pain specific. The difference between values and goals is that goals have an endpoint and values don't. Goals are achievable, values are the way in which we lead our lives throughout the whole of it. So some examples then. So some patient examples that I've had. So a lady came in to see me and she had a goal of returning to dancing for 30 minutes once a week with her partner. I could tell them a physio, the goal was as smart as we could make it. And through discussion, we identified that the underlying value of this goal was her spending time with her partner and also music. She really enjoyed listening to music. I had another patient who came in and her long-term goal was to be able to walk half a mile to take her kids to the park twice a week. And the underlying value here was being a good parent. So helping patients to think long-term, and I usually say 6 months just to put an arbitrary figure on it, because 6 months is far enough away to make big goals, but not close enough that it feels quite daunting. So thinking long-term and helping to work backwards to visualize a path on how to get there. This is obviously really important because big goals can feel really overwhelming and unachievable at the start. So helping patients break these down into steps they can take to achieve a short-term goal in the next week or month is really helpful. The long-term goal should feel out of reach, ideally, so it is far enough ahead, but the short-term goal should feel within their grasp. If it's not, then break it down further to make it more achievable. So taking the examples from before of the two ladies that I just spoke about, the first lady, whose goal was to, her long-term goal was to return to dancing 30 minutes once a week with her partner, we broke this down to finding a suitable time in the week for you and your partner to listen to some music and that you'd like to dance to. So still meeting the value of spending time with her partner and also music. It's just engaging with those values in a different way with the aim of moving towards her long-term goal. For the second lady, whose aim was to walk to the park twice a week with her kids, it was to begin walking 5 minutes daily down a few houses and back every day for the next week. Achieving the short-term goals gives a feeling of success, motivation to continue, which makes sure that it's an automatic behavior because of that positive feedback loop. Without breaking down goals, the big goal can be overwhelming, reduce motivation, and lower mood as well. So coming towards the last few kind of slides around the management side of things before I talk a little bit about medication. So how do we help our patients lay down the path towards their goals in line with their values? Well, this is through habit formation. So the 3 steps of habit formation are choosing a desired behavior and scaling it down to a tiny daily habit or action, finding where it fits into a routine or associate it with another habit, and celebrating the habit or behavior to feel a positive emotion in the moment. These 3 steps are so key to form a habit. Now, every habit will have a cue, a craving, a routine, and a reward. So what we want to do when we're forming a habit or trying to form a habit is making the cue obvious, making the craving attractive, making the routine easy, and making the reward satisfying. If we're trying to break bad habits, we just kind of invert this. So we're making the cue less obvious, we're making the craving less attractive, we're making the routine harder to do, creating more friction between it, and we're making the reward less satisfying or not satisfying at all. So talking about these 4 laws here of behavior change, with making it obvious, this talks about creating the optimal environment by changing the first thing that you see when walking into a room or unlocking your phone, etc. And the idea of this is to create the path of least resistance between the patient and their desired activity. So deciding when and where the habit will live is really, really important. And you can link this with habits already formed. So for example, brushing teeth, boiling the kettle, we can put a habit that we're trying to do on top of that. So it might be that a patient would like to improve their ability to reach into a cupboard. And what they might do while the kettle is boiling is practice that movement. Making things attractive. So it's really important that patient's social circle supports the behavior they're trying to change, and potentially joining a group where their valued activity is the normal activity can be really helpful. Good use of this is things like social prescribing, which can help with this, but also groups out there such as parkrun. The reason things like parkrun work really well when we think about it, it's just people running a 5K around a park, which people can do alone if they wanted to. But the main thing that makes parkrun so successful is that you're doing it with people who share a goal and a value with you. And that's what draws people towards parkrun. Making it easy. So starting slow and building up. The hardest part is always starting. So what is the most achievable step that a patient can take that they can commit to? So going back to the ladies that I spoke about earlier, the one with the aim of dancing with her partner for 30 minutes once a week. The easiest start that we had for her once listening to the music had happened was dancing for 2 minutes once a week. Okay. The lady whose habit was to walk to the park with her kids was to walk 5 minutes twice a week, as I mentioned. The habit must be formed before it can be improved. But the most important thing is creating the path of least resistance. So what is a step they can take that almost feels ridiculously easy? We've had patients before who've come in and they want to start walking and just said the first step is putting your shoes on and standing in the garden. Don't wait to walk anywhere, just stand in the garden. Now, likelihood is they're going to probably do a little bit more than that, but even if they don't, that's fine. They found a time in their day and in their routine when they're going to do that, and then that can be improved from there. Lastly, satisfying. So creating a reward immediately after completing the behavior creating the award immediately after completing the behavior in line with someone's values is something that can just make sure that we're sowing that positive feedback loop back in. This could be things like sharing success with a friend. So if someone has a shared goal, giving them a call, sharing the success. It might be, an allowance to have some more me time, soak in the bath, watching a favorite Netflix show, whatever it might be. I often write now in my notes when I'm thinking about actions that the patients want to take to move towards their desired behavior. I write down in their plan, obvious, attractive, easy, satisfying, and then I write things next to it that me and the patient have agreed on that they can just work on that one thing before the next appointment. We can give a list of exercises. We can give a sheet of exercises with 8 to 10 exercises on. But I would argue that actually picking one thing and doing this one thing well, using these rules here, is going to be more helpful for the patient moving forward. So keeping it in line with their values, the goals they're trying to achieve, and actually how do we break it down and make it obvious, attractive, easy, satisfying until the next time they come to see you. You may have noticed if you read the book Atomic Habits that a lot of those things on the previous slide are from that book, and that was written by James Clear. If you haven't read it, I definitely would recommend it. It's fantastic. Personally, coming up with habits for myself, but actually more helpful than any of the behavior change stuff that I've read from a clinical perspective. I found this is actually really quite applicable in clinic as well. Okay, so this is something to have a think about after this session, just because of time today, but it's something to have a think about and take forward with your patients who are not currently able to perform their meaningful activity in the same way they used to due to their pain. So instead, think about how can you help them engage with their value underlying that activity in a different way. Okay. The reason I've used goal on here on this slide, and the reason goal is singular, is it's singular intentionally because I suggest only choosing one of your patient's goals to work on initially. Just because too many things to focus on often means that we are spreading the attention, and also just thinking about the cognitive load with some of these patients when they come to see you. Often just having one action from the appointment is more helpful than having multiple. We know that things can snowball with patients with the pain cycle. We've seen how things can snowball in a negative way, but snowball effects can also happen in a positive way. So focusing on one goal can also have positive effects on other areas of their life as well. If you want to take a picture of the slide, it's a really good exercise to maybe have a think of if you've got any particularly difficult patients that you're struggling with at the moment. Maybe they're representing and things like that. Take a picture of the slide. Otherwise, I think we are going to share the slides anyway at the end of today. Okay, so the last bit today that I want to talk about, and hopefully we're okay for time. I think we've got a bit of time. We're going to talk about just pharmacological management, really, because I know this is always a hot topic with pain medication when people are coming to see you in FCP or primary care clinics. The reasons I'm covering pharmacological management today is it's helpful to identify whether a patient's pain medication is firstly appropriate and likely beneficial or not. It can also help us manage expectations about medication for persistent pain, including the limitations of medications. It's helpful to be familiar with the current NICE guideline recommendations on medication, as this changes for the different pain types that we've discussed today. And also it's helpful to identify those patients who may benefit from a pain medication review. Some of you on the talk today might be prescribers yourself, which is great, but otherwise medication reviews might need to be done by an APP, ANP, GP, whoever you've got available in the clinics that you're running. So we're going to go through the nociceptive, neuropathic, and nociplastic pain, and I've just picked examples of these from the NICE guidelines, osteoarthritis being the example for nociceptive pain, just to show how the recommended medications for each of these different types of pain differ so much. Often if we haven't done the bit initially in identifying the underlying cause of pain, then the medication discussion can get really difficult and very grey. Of course, pharmacological treatments are best used alongside other non-pharmacological treatments, and often, hopefully, not the first port of call with medication. Hopefully, we're looking at other treatments instead, and obviously, we want to be using these for the lowest effective dose for the shortest possible amount of time. So, in the table on the left-hand side, if the option at the top is ineffective or unsuitable, then it's to consider the one below. So for osteoarthritis, think about topical NSAIDs first of all, especially with knee OA or hand OA, then moving on to oral NSAIDs plus things like lansoprazole or omeprazole before going on to intra-articular injections. We want to avoid paracetamol or weak opioids unless it's used infrequently for short-term pain relief, and all the other options are contraindicated, not tolerated, or ineffective. And obviously, the injections can be considered when other options are ineffective or unsuitable, or to support things like physiotherapy and exercise. But of course, we want to explain that these are already providing a short-term relief most of the time. Neuropathic pain. So again, same thing here. So the ones at the top, to be used first, and if those are ineffective, then moving down that table on the left. This is for all neuropathic pain except trigeminal neuralgia, and there is a separate guideline for sciatica. But effectively, what we're looking at with neuropathic pain is amitriptyline, duloxetine, gabapentin, or pregabalin. And if one of those isn't effective, then it's trying one of the remaining three there as well. Tramadol is only for acute rescue therapy if it is needed, and we can consider capsaicin cream for people with localized neuropathic pain who want to either avoid or can't tolerate oral medications. Wanting to avoid strong opioids for neuropathic pain, and SNRIs other than duloxetine, so things like venlafaxine, we want to avoid those things. And then lastly, chronic primary pain that most of today's talk's been on, that nosoplastic pain category. So what we're looking at here is antidepressants. So actually every medication now is on the not recommended list for chronic primary pain, apart from antidepressants, specifically tricyclics and SNRIs like amitriptyline and then duloxetine. If that's not effective, looking at alternative antidepressants as well. There's a whole load on those not recommended lists now, as we can see, and that's because a lot of these things are focused on nociceptive or neuropathic pain, as I mentioned before. So as you can see here, the guidance around medication is so varied depending on the type of pain. So it really, what we need to be doing is getting that bit right. First of all, what is the type of pain that the patient is presenting with? Because everything then falls in line after that, and our treatments are then based on that as well. The biggest issue I think we've got at the moment is tests don't show nosoplastic pain, and we are trying to use the same treatments and approaches for nosoplastic pain that we use for nociceptive and neuropathic pain. And unfortunately, those things are just not working. So we need to shift towards the values-based approaches that I spoke about today. Okay, so just to recap, so the consultation, we've gone through assessing the type of pain, delivering a little bit of pain education, as I mentioned, with the hand over the flame analogy. We've looked at what helps versus what does not help, depending on the pain type, and all of that should be used to make a shared decision with the patient, whether that is continuing with you in the FCP clinic or a referral on to another service. Okay, so yeah, I'll take any questions now. I'm just looking at the chat. I'll just have a sip of water.
Yep, so you've had a few come through, Mahin.
Yes.
The most upvoted one is from James Holland, who has asked, when looking at the golden shift, I often find this difficult, doing this without the patient being fully satisfied that they have been fully worked up with imaging, etc. So how do you manage this? Would you tend to image, or if there wasn't a clear indication for that, or are you against imaging in those situations?
Yeah, it's a really tricky one. So I think first of all is, has that patient had a proper explanation around why imaging may not be suitable? A lot of the time we say, because you don't have any leg symptoms, I'm not going to image. It's probably not enough for the patient. It's really helping them to understand why imaging doesn't always show pain, and going back to actually all those factors that may be involved with it, and especially as pain goes on and becomes chronic. If the patient is absolutely adamant and they feel like they can't move forwards without that, then often sometimes we do need to investigate. And that's not because we're suspicious a lot of the time, but just thinking about resources that are being used every time with a patient coming back and what is going to help the patient reach that stage of acceptance sooner. Sometimes if they haven't had any previous imaging, they've had pain for a long time, there might need to be further investigations that are done to help them move along that journey. I know that's something that we often try to stay away from. We shouldn't be doing it for reassurance, absolutely not. But if pain has persisted for a long time, it hasn't improved, it's not responded to conventional treatments or what we'd expect to help it with, then there's a little bit more indication for imaging, I suppose, if they've not had a previous scan. They have had a previous scan, but it hasn't shown anything, and then they're presenting with the same symptoms but worse. It's probably just an explanation that actually pain goes beyond what we can see on scans alone, and it's quite common to have a scan come back normal and not show an explanation for pain, with pain still presenting.
Brilliant. I think that addresses that neatly. So the second question we've had is around ACT, and when you make the decision to involve ACT in your management approach for someone with persistent pain?
Yeah. So I think I'd use it really for every patient that is presenting with chronic pain, especially if it's nociplastic chronic pain like fibromyalgia that we mentioned. It's not that I would necessarily deliver psychological therapy using ACT myself, but using those principles like we've discussed today, I think should be used for all patients. Of course, even patients who are presenting with other types of pain still have biopsychosocial factors that are involved with their pain. It's just where on that sliding scale do they sit at the moment? Is it more towards the nociceptive type of pain or tissue-based, or is it more towards the nociplastic pain? And if it's more towards the nociplastic, then that's probably when I'd use some of the ACT strategies that we've mentioned today. But more often than not, if they present with chronic pain, I'll be using it for all patients, really.
Yeah, brilliant. I think that's obviously ACT has become one of the things that is particularly well used as a model in persistent pain and pain clinics now. And I think it's somewhat in a bit of tension, isn't it, with the hope of recovery for some patients in terms of recovering from their pain. And this is a selfish question from my point of view, but I'm wondering how you might walk the line between telling someone they have to live with it forever and then still providing hope in the clinic for them.
Yeah, I think that's tough. I think it's really just reframing what we're trying to achieve here, and I think it's recovery looks different for everyone. So initially, patients might come thinking that recovery means being pain-free, or at least reducing the pain to an amount where it's not really bothering them that much in life. But I think recovery can also be returning to activities they've not done for a while, returning to socializing, and taking part in things that they value and find really important. So I think it's just reframing that is actually, there is a possibility that your pain may not go away. I can't say for certain, but there is a possibility that we might need to just speak about. But even though that is the case, how can we move forwards then? If pain's going to be in your life anyway, how can we take it from being in the driving seat and putting it into the passenger seat? What are the things you want to get back to in the presence of pain? Because that's the stuff that we can help with. That's probably how I frame it to patients.
That's great. Thank you. Okay. We've got loads more questions coming through now, so I think we might have to be slightly more selective. Okay. There's the most upvoted one is, do you not find that once you embark on a valued approach and the goals are being achieved, the patient's pain starts to decrease?
So when we do start with those, I often do think they do. Often it can. So it's something that we're finding a lot in our pain management programs. Just to give you a bit of an overview, the pain management programs we have are an 18-hour program over 6 weeks, 3 hours a week for 6 weeks. And what we're finding is we use a lot of these approaches. And by the end of it, people report significant improvements in things like anxiety, social connection in terms of getting back into social situations that they haven't for a while, getting back into activities they haven't for a while. Some people say their pain is exactly the same, and that hasn't changed, but they've been able to engage with other things. Some people say their pain's improved, and I think it's just because, again, if we're thinking about what happens with the brain with that way up of evidence of danger and safety, getting back to things that people value is evidence for safety rather than danger, and that's why it can just help to turn down the volume of pain.
Brilliant, thank you. One of the anonymous attendees has asked if you might share some analogies that you use to explain persistent pain. So I'm making the assumption that this might be some metaphors that you might use in clinic.
Yeah, so the ones I kind of like to use is the burglar alarm one. I'll briefly go through a condensed version, but I use this to explain fibromyalgia in particular, but can be used for all chronic pain. So if I was speaking to a patient, I just want you to imagine for a second that you have a normal standard burglar alarm fitted in your house. You go to sleep at night, a burglar breaks in, the alarm goes off as it should do, warning you that there's a threat or a danger and that somebody's in your house. This is what happens when we have, an inverted commas, a normal pain system or not a chronic pain system. I want you to imagine now for a second that you've gone out and you've spent lots of money on this high-tech burglar alarm system. It's got infrared sensors, motion detectors, heat sensors, the works. It's got everything. But you also have a cat, and often sometimes I take the name of a pet that a patient has. And let's say this cat's called Tom. Tom runs across the room in the middle of the night, setting the alarm off, stating that there's a threat or a danger, when actually it's just Tom. This is what happens when our pain system becomes overprotective and sensitized. It's now warning us about threats and dangers, when in reality it's just your pet cat, Tom. And that's one that I use. There are lots of other good ones. The car alarm analogy is a good one. There's loads on there. I think finding something that you feel really comfortable in explaining is probably the key. And when you've got comfortable using one, also just testing it on patients and getting feedback. So often at the beginning, when I started using different metaphors, I would ask patients to feedback on how that sat with them and being really honest. Sometimes you might get patients who feel like, actually, that was a bit condescending, that suggested that this was psychological only. So really trial a few different ones and get some feedback from patients, really, and just ask them how that kind of sat with them, and just because you're testing it out.
Brilliant. And I imagine by asking them, it allows you to gauge their understanding of what you've told them as well, doesn't it? So it's got that dual function.
And it's a good one for them to go home and then explain to their families as well, because that's a big thing that people report, is that the families or people that they live with are not very understanding of their pain. So it's a good one for them to go back to. That's why metaphors work quite well, because they take a very complex concept and explain it in terms that are familiar with people. And that's why metaphors are a really good way of explaining pain.
Brilliant. There's a few things that have come through in the chat as well, so I'll just put some of those in. So question from Darren Finnegan, just asking, how do you incorporate this persistent pain conversation in a time-strapped first contact physio consult? So for instance, most people might have 20 minutes for that. After you've got subjective, your objective, whatever education around that specific condition in there, where do you see this fitting in?
Yeah, so I mean, it could work a few ways. So it depends on what you found after that assessment. So actually, if you find that, and you'll get some of this from the subjective, this patient's really struggling functionally, they've got high pain sensitivity, it's been going on for a number of years, and they haven't had input recently, then in an FCP clinic, referral onwards may be appropriate to either a pain service or a physio service where there is more time. Alternatively, again, depending on where the patient's coming in, if they've been seen recently, it could be that actually you just spend that appointment, rather than even going through the full assessment that you might prioritize a little bit more to the education, just checking that there's not been any changes since they last saw you, and prioritizing education in a short way, whether it's something like a metaphor that I've just explained, the flame analogy that I used earlier on, or as a third option, it's if they're a fairly new presenter, you've gone through the assessment, is actually then booking them back in for an appointment in X amount of time to go through specifically just the education piece, not reassessment again. And also you can maybe send them some materials as well to look at in the meantime before they come to see you. So the Flipping Pain website, as I mentioned at the beginning, has some good resources on there to help understand pain.
Brilliant, thank you. I've got a question from Catherine Johnson, just saying, do you think it can be within our scope of practice as a first contact physio to diagnose a patient with something like fibromyalgia? And if you think that is the case, do you have any tools that you might use to make that diagnosis? And just some context for that question is that often GPs are reluctant to make the diagnosis and will then refer to rheumatology, which it seems a fairly inefficient use of rheumatology time. So do you have an answer there?
Yeah, absolutely. This is a really good question, actually, because the guidance has changed recently. I want to say 2 years ago. The Royal College of Physicians have released new fibromyalgia diagnostic criteria and guidelines. We can find it on their website, and maybe we can find it and link it in the chat. But fibromyalgia diagnosis doesn't specifically fit under rheumatology anymore. So any clinician who works with people in pain who feel competent can diagnose with fibromyalgia. So I actually encourage people in our MSK physio service to get used to diagnosing fibromyalgia, or at least assessing for it. Often patients would have had some sort of workup, bloods or whatever, before they've come in, or previously, especially if they've been living with pain for a long time. But obviously, if they're in the absence of any inflammatory features, but they are presenting with widespread pain and things that are pointing more towards a chronic pain presentation like fibromyalgia, using the diagnostic criteria can be really, really helpful. Yeah, it's the Royal College of Physicians fibromyalgia diagnostic criteria. If you type that into Google, it'll come up, and there's a PDF. As well as the diagnostic criteria that's there, there is an information sheet for clinicians and an information sheet for patients, both really useful to use. It's just a one-pager, so it's really useful to hand out to patients as well to help them understand it. But it is so inefficient going to rheumatology unless you're suspecting inflammatory conditions or connective tissue disease or whatever it might be. Actually, it's probably worth looking and upskilling to see if you can diagnose fibromyalgia yourself, because it doesn't have to be a rheumatologist to do that. I think I've answered that question. I know there's a couple of parts to that one.
Yeah, no, absolutely. I think you've covered it there, Mahin. Okay, we've probably got time for just one or two more. So there's a question here from Mohammed Mahdi saying, I am seeing a patient with chronic knee pain tomorrow who is a veteran, that possibly due to an injury a few years ago, and the pain is severe. It's been preventing sleep, and they've been to A&E 4 times in the past few months. This person has suicidal thoughts, PTSD and depression, and was referred to them by their GP in the hope that they might help. And they believe most likely it's nociplastic pain. However, they're wondering whether it's wise to talk about that in their appointment with them, and how they then might signpost this person after that conversation if they were to have it.
Yeah, I think it's definitely important. If you have a strong suspicion that there is nociplastic, and you feel that it is perhaps related to his previous time as a veteran, the trauma that's come on from that, I think sowing the seed initially can be really, really key. I usually explain things to patients that pain is our protector. It responds to lots of things that the body perceives as. I use the body initially if I haven't had time to go through a long talk, just because if I feel like if I say brain, people automatically they're kind of the walls go up and they assume I'm talking. Assume I'm saying that the pain is in their head, so I use the word body initially as a softener. But I usually say pain's our protector, and our body responds to anything pain responds to anything that the body sees as threatening. That can be injury. If you twist your ankle, pain's there to stop you from walking on it, but it can also be related to other things such as stress, poor sleep, lifestyle changes, or any previous trauma that anyone's had. Often a patient will then mention that they may have had some trauma in the past, but I also talk about the relationship between chronic stress and trauma in involvement in chronic pain as well. So it's just sowing the seed really, and just mentioning that we know that there is a link between trauma and chronic pain. I think it's important, first of all, and just tying it in with the subjective as well. So if the patient actually clearly says that this came on after a traumatic event, psychological or physical trauma, and just linking that in to use that with your explanation. It sounds like this patient, if this has been seen in an FCP clinic, it sounds like this patient probably would need further input. To be honest, I don't know if they're under a mental health service at the moment, but having some input psychologically alongside other things that you're doing in your FCP clinic or referring on for physio can be really, really helpful, because if there's some unprocessed trauma there, that can be a bit of a barrier in terms of helping people to manage their pain. So referring on for that is important if not already done so, or referring on to the pain clinic if that's available to you in your area for this chat, because it does sound like this might require a bit more input.
Thank you. I think probably just time for the last one now. We have been putting the link to give us some feedback in the chat for this for today's event. So it takes just a few moments to fill it in. So if you wouldn't mind doing that, that would be fantastic. As you can see, there's a QR code there, or you can type the web address in. So just one final question, and I will give James Holland, I'll give you 2 bites of the apple here. You've put a few questions in here, but I think this is quite a nice one to finish on. Do you have any good techniques for patients that have persistent pain, but they aren't fear avoidant? So maybe they are I think the sort of term might be a persistence coper, or someone that really pushes their pain. Do you have any advice for James in this situation?
Yeah, I think the one of the key things when we're exploring all of these topics is actually helping the patient to see that you've understood what they've said when they've told you about their journey or their history and the subjective. So what I like to do is I like to draw out the boom bust cycle, because often that's what endurance copers will go through. So for those of you who've not seen it before, the boom bust cycle is when we have sudden increases in pain because maybe someone's had a good day, followed by a bust in activity or decrease in activity because the pain has increased because of the increase in activity. People have a couple of days to recover, activity levels increase because of a good day, and then they fall again. And over time with the boom bust cycle, we see their function and activity levels reduce over time. So I draw that out for patients, and more often than not, similar to the pain cycle, patients go, yeah, that's absolutely what I've done. And then talking about things like pacing, planning, and prioritizing. So for these group of patients, actually doing more is probably not the thing they need, but actually looking at how they can break their activity in a week up into manageable chunks with periods of rest in between. So it involves planning the week as a whole and putting in the things that are most important to them first and prioritizing activities. As just a quick example, let's say this patient has a wedding to go to on Saturday. They put that in first. Friday might be a more restful day. Sunday might be a more restful day. And then let's say they've got less important things that they need to do, like clean the house. That might be broken up into over a 2 or 3 day period rather than doing it all in one day and then busting because of that. It might be actually spreading that out into a week. So it can be helpful to go through a week's plan with patients as well to help with the 3 Ps, which is pacing, planning, prioritizing.
Brilliant. Thanks very much. I'm sure we could keep chatting about this all night. I think we've really struck on a hot topic here, but we'll have to leave it there, I'm afraid. So thanks so much for your fantastic talk there, Mahin, and your really insightful answers. So just final words, really, just to wrap up. Thanks again for attending and everyone that stuck around for this. We do have some more events coming up. So if you keep your ears to the ground about our event coming up in February with Joel Brannigan Strength and Conditioning Workshop, which will be in person. We are also restarting the NEMS research grant, and I am your research officer, so I'll be involved in helping set this up. But more details to follow, and they will again be in February. And again, if you have an opportunity to leave us some feedback, it would be much appreciated. And just thank you once again, Mahin, for your time.
Thank you, everyone, thanks for having me. It's been I really enjoyed doing these talks, and yeah, thanks for hosting me. And please, if you have got feedback, I would really like to hear it, because obviously just wanted to make these talks even better for the future as well. But yeah, thanks again for having me, everyone.